Hello everyone and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would like to now turn the meeting over to your moderator, Tanya McDonald, Director of Programs at Canadian Foundation for Healthcare Improvement. You may begin.
So thank you and welcome everyone to our second webinar in our Long-Term Care Plus Acting on Pandemic Learning Together series. So today we have the pleasure of hearing from the experience from Kingston, Frontenac, and Lennox and Addington Public Health and their experience with respect to preparation and prevention strategies related to the pandemic. So today we have a whole panel of speakers who will be here to share their experience with us, including Dr. Kieran Moore, Medical Officer of Health of Kingston, Frontenac, Lennox, and Addington Public Health, Ms. Teresa Miller, who is a resident in Providence, Manor, Ms. Crystal Mack, Dr. David Barbier, and also Dr. Pierre Robichaud. So before I pass on to Dr. Moore, I'd just like to go over today's objectives. So today we are here to learn from the approach used in Kingston to prepare and prevent outbreaks in long-term care facilities, to offer concrete strategies for organizations to prepare for future outbreaks, and also to share next steps to participate in the Canadian Foundation for Healthcare Improvement and Canadian Patient Safety Institute Long-Term Care Plus program, Acting on Pandemic Learning Together. And so now I will pass over the microphone to Dr. Moore. He is the Medical Officer of Health for Kingston, Frontenac, Lennox and Addington Public Health, and is a Fellow of the Royal College of Physicians and Surgeons of Canada in Public Health and Preventive Medicine. He is also Professor of Emergency Medicine, Family Medicine, and Public Health Sciences at Queen's University in Kingston, Ontario, Canada. He received his medical degree from the University of Ottawa in 1985 and subsequently received his specialty certification in family medicine as well as emergency medicine from the College of Family Physicians of Canada. He has a master's degree in disaster medicine as well as public health and a diploma in tropical medicine and hygiene. Dr. Moore has extensive experience in public health surveillance systems, pre-hospital care, and multidisciplinary research projects. His main areas of interest are the evaluation of various data streams for the early detection of outbreaks, opioid and drugs of abuse surveillance, as well as the assessment of deprivation distribution in populations. His work with Queen's University Public Health Informatics Team, acute care and healthcare worker absenteeism, real-time surveillance system and provincial telehealth data have been published in the Canadian Journal of Emergency Medicine, the European Journal of Emergency Medicine, Advances in Disease Surveillance, and the Canadian Journal of Public Health. So I will now pass over the microphone to Dr. Moore.
Thanks very much, and thanks for the opportunity to speak today. I hope everyone can hear me okay. I will be speaking on COVID and the long-term and retirement home experience that we've had here in KFLA Public Health. I'm going to review the experience of COVID, the Ontario approach, and I'm sorry in advance, I am much more familiar with the approach that Ontario's had with our long-term care and retirement homes. I'll give a little background on KFLA Public Health, a little background on our pandemic approach, and next steps and key messages, if that's okay. So just an update, the total number of cases in Canada continues to go up, and today 313 cases alone in Ontario. So those numbers go up, and we know that the age propagating or having the highest rate of infection are the youth from 20 to 29 in our communities. So that doesn't bode too well for the winter as we start to head indoors. We can see that cases will probably rise even more across the country. But differentially, Quebec, Ontario, BC, and Alberta have had higher rates, but all provinces have and are trending upwards. And most of the time, public health at a local level is able to attribute the cases to either an outbreak and or that you've been a close contact of an outbreak. And certainly early on in the very first days of this, all cases were travel related. But now you're finding that we can't identify the risk. So please continue to monitor the no epidemiologic link area of this donut. because if that's expanding, then we cannot put in good control measures, and we may have ongoing community spread because we can't identify the link. So please monitor that data closely. The number of cases across long-term care facilities in Canada is startling. Quebec and Ontario certainly had the highest number of cases, but 1,125 for all of Canada. British Columbia, relative to its population, did very well, so did Alberta, and the other provinces had low community spread and hence very low risk of transmission within those facilities. And sadly, we've had 9,981 staff cases as of the timing of this data, and 16 deaths of staff members, and sadly 6,784 deaths amongst people living in the long-term care facilities and retirement homes. These numbers, sadly again, are consistent in other jurisdictions where the elderly have the highest mortality rate because of the aggressiveness of the virus in that population and the vulnerability of the population. So we must continue to try to protect this population as best we can and to strengthen our long-term care and retirement home settings. This is just the orders that were put in place to protect patients and staff within long-term care facilities. It seems long ago, but it was just March 12th that we had memos regarding the active screening of all staff entering into long-term care facilities, and I'm very confident that these directives were similar across multiple provinces and probably similar timing. The direction on the mandatory use of personal protective equipment, the control of who can visit long-term care facilities, and the limitations on who can enter or leave long-term care facilities, and the requirement for active screening and testing. These continued as we went through the epidemic, and we had further memos on controlling the outbreak, which are all documented, and certainly in April, April 24th in Ontario, had to get the Canadian Armed Forces involved in some of our institutions. We reached out to the Public Health Agency of Canada, and there had to be memos put in place of mandatory control of some long-term care facilities in Ontario by their partnered acute care facility. And now we've had some return to normalcy as we prepare for the fall, and have been trying to have policies and procedures in place to further strengthen our long-term care facilities, retirement homes across Ontario and Canada, and trying to improve multiple aspects of the care that they provide to their community and population. So in Ontario, there have been reviews of what's going to be required to improve the long-term care and retirement home structure. And certainly we've learned that we have to have better collaboration between acute care, public health, primary care, and the long-term care and retirement home sectors. We need to strengthen and support the administration and leadership, the medical leadership, the nursing leadership of these facilities. I think we've learned also that we have to have improved in prevention, infection prevention and control. We also need good access to personal protective equipment. We have to strengthen our human health resources, and when we've done our review locally and surveyed all of our facilities, certainly human health resources are key going forward to support. And also having the capacity for mandatory management orders if a facility gets into a significant outbreak mode and can't staff fully. You need to be able to have the partnerships to support them. The rates of COVID-19 do correlate to high density areas of the country, also where you have the association with poverty and ethnicity. Those are known areas, so you can look at any major city of Canada and see differential rates of COVID based on the density of people and their underlying social determinants of health. And one would think that the facilities, retirement homes, long-term care facilities that are closer to those areas will also have a higher rate of COVID-19 infection. We've been fortunate in KFL&A that we were able to protect our long-term care facilities in retirement homes, that they did a wonderful job protecting their patients and staff, and we had only one outbreak and no deaths within any of our facilities. And our sister health unit in Hastings, Prince Edward did as well, very similarly in terms of outcomes for their population. And I think we're in a better place now across Ontario. We have better infection prevention and control, better education, better access to personal protective equipment, better outbreak management. And it does put us in a very good position heading into the fall, because we will see a rise in cases. And sadly, we have to annually have to deal with influenza. And it may be that we're dealing with both in some instances. So we were in the news because our facilities did so well. We are a city and community in KFLA of institutions, so we have a high number of correctional facilities, none of which had outbreaks, and none of our long-term care facilities had outbreaks. You can see from our population demographic, it's a boom-bust echo. We do have a high proportion of retirees in our region, and a high number of long-term care facilities as a result. And roughly we're around 204,000 people nestled between Toronto, Ottawa, Montreal, and along the St. Lawrence River, so very close to New York. So in our area, we had 27 homes, 11 long-term care facilities, 16 retirement homes, roughly 3,000 residents. We had one case and one staff that our local health unit in partnership with the facility was able to quickly identify. And as a result, we had no hospitalizations from our long-term care facilities, and as I said, no deaths. We have had a long, outstanding partnership with our long-term care facilities and retirement homes. We work with them annually on influenza prevention and early detection and response, as well as any management of any outbreaks. And I'm very proud of the nurses on our staff who've built those relationships longitudinally. And I think our long-term care facilities feel supported in our region because of the strong partnerships longitudinally. And we attend their infection prevention and control committees annually. So those long-term relationships helped us as well. We reached out early in the outbreak with strong communication, collaboration, coordination, and cooperation. So those C's, the rule of C's really helped us longitudinally because we wanted to support our facilities, knowing that the outbreaks in Vancouver, in Washington, and the morbidity and mortality curves from Wuhan clearly told us that the elderly were the most at risk. And we do yearly updates, as I said. That's part of the Ontario Public Health Standards for influenza outbreaks, and we do annual education on infection prevention and control. And we have dedicated infection prevention control nurses working with our long-term care facilities throughout, in particular, the respiratory season. As well, we were fortunate in September of 2019, and if you recall, we had a significant influenza season in Australia and New Zealand at that time. We were concerned whether there was a new virus and or a new threat. And so we brought all of our partners together in September of 2019, so roughly 5-6 months before COVID. We had over 100 participants from our long-term care facilities, retirement homes, acute care partners, paramedic partners, primary care partners, emergency medicine, and public health. And we table-topped several events, such as outbreaks of the virus within a long-term care facility. How would we mobilize to support the staff in those facilities? How would we allow for transport? What ventilatory capacity could we have in a severe influenza season? Knowing that influenza has a terrible, long impact on the healthcare system and on our communities on an annualized basis. And we did that with our 3 sister health units and all of our partners. And we came out with a work plan from this, circulated to all partners, and it basically outlined the C's. Communication, collaboration, cooperation are key to success when you're looking at any viral threat, and supporting each other through it. And it was well received, and the report was disseminated and discussed, and we are in regular communication with our partners, as I've said. Our partners are also linked with the acute care sector. So I hope that during the pandemic, our long-term care facilities felt supported. I held weekly teleconferences initially with our medical directors. Our lead for infection prevention control, Lori Conway, held meetings regularly with administrators and nurse leads and nurse practitioner leads within these institutions to support them, ask them what they needed. You know, with all those medical directives coming through, it could have been confusing, and we wanted to ensure that everyone was on the same page. They understood what was being asked of them and that it was being appropriately and properly implemented on a timely basis. And that was the point of the ongoing teleconferences. As well, we wanted to ensure that if they had a case of COVID, they would know what to do, who to call, how to test, etc. And we, during the pandemic, augmented our inspections of seniors' homes, long-term care facilities, because we were no longer, after March 17th, inspecting restaurants. Our public health inspectors, who have great expertise in infection prevention control, as well as outbreak detection, a good foundational understanding of med-micro, were partnered with our long-term care facilities. I wanted the facilities physically visited to ensure that signage was up, that the screening was being done properly, and so our inspectors went out on a regular basis to those facilities, and we eventually paired our public health inspectors with a public health nurse, and were able to provide dual support from the nursing and inspection side. So we started inspecting our facilities early, so beginning of March, as soon as we were anticipating the restaurants being closed, and the pandemic was declared on the 11th of March. Prior to that, we had numerous telephone calls. We were ensuring that they understood the risk, that their population was vulnerable to this infection, and that we wanted to reduce the risk in their facilities. And then the lockdown came in place, as everyone recalls, in Ontario at least, where restaurants, businesses were closed, schools were closed, and that allowed us further movement of staff within our facility to be able to support our long-term care facilities. And it certainly helped us mobilize our staff, not having to deal with school health issues, university health issues, and basically concentrate on our correctional facilities and our long-term care facilities, as well as getting our assessment centers up. So we went through many rounds of inspections of our facilities and created checklists with audit tools, monitoring for hand hygiene and the use of personal protective equipment to further strengthen and support our facilities. And this certainly helped us understand their preparedness, but I think they were well received in the field to have them in place. This is an example of our checklist. So we look for signage at reception initially, that visitors were being screened, and then when there were no visitors, we wanted to ensure that anyone going into the building was limited. We also wanted to ensure that the administration had clear medical directives, that the residents were being screened, that they were testing appropriately, and that the staff, we wanted to ensure the staff were putting on and donning and doffing all equipment appropriately, and that also they knew the testing strategies, because the testing strategies changed over time of who was allowed to be tested, at what frequency, etc. And we did use our inspections in a progressive way. So first was basically to educate and to bring everyone onto the same page and to ensure that we had good quality improvement initiatives in play. And then some of our partners needed to be reminded through the issuing of an order, and we did have to use fines. So we did use progressive enforcement as needed to ensure that all of our facilities were adhering to best practices. And then in Ontario, we had to do universal testing of all of the patients and staff, and we were able to do that quickly in our region, and all of those tests were negative. It also helped tremendously that we in KFL&A were one of the first to have testing sites up. I have to thank our hospital in Napanee and Kim Morrison and her team that got rapid testing available very early on, as well as our staff were partnered with Kingston Health Sciences Center and got a community testing strategy in play very early. It was tremendously helpful to have early testing, early isolation and quarantine of contacts so that public health could limit the spread of this virus, and we kept our community rate very low. We did have a significant early first attack rate, but because of the accessible available testing, that really put us in a good position. And so we were able to partner with the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Initiative and provided some input on the key areas of preparation, prevention, people in the workforce, pandemic response and surge, and then planning for COVID and non-COVID care, and we're able to comment on these major issues. And I was happy to read that cohesive document that they circulated with many people's input from across the country. Certainly from preparation vantage point, the IPAC standards are key and training staff is key. Tabletop simulations are essential, as well as good partnerships in the community. And on the prevention side, we were, as I said, blessed with good accessible testing from our lab early, and we had very good contact tracing protocols in place that prevented high community transmission, which then protects your long-term care facilities. And we put in universal masking early as well. Also had great partnerships with the acute care sector, where our medical directors, nurse practitioners, nurses could call emergency physicians for consultation and or internal medicine for consultation without the patient having to be transferred. And certainly staffing continues to be a major issue across the country. We want to maintain staffing, their good, strong working conditions, keep them protected with adequate IPAC and PPE, and maintain their mental and physical safety. And that's difficult when we have to limit staffing to one facility, and we're going to have to work around these issues and create an expanded workforce willing to work in this environment and paid a decent wage to do so. We also have to plan for the surge, and when you have a surge of cases, you're also going to have a surge in absenteeism. As people have to stay home, they may screen negative, or they have to take care of family members, etc. So we should all be preparing for 30% absenteeism going in to the fall, and rapid testing, and also preparing for co-circulation of COVID-19 and influenza in our long-term care facilities, retirement homes. Certainly we felt like we supported our clinical leadership, the medical directors, nurse practitioners, administrators, by the regular telephone calls. We do continue them all summer, and we'll be accelerating them as we go into the fall. Because typically the fall we have our annual meetings for influenza preparedness, and won't be able to have any large gatherings here. We'll have to be using all the electronic means to our disposal to keep everyone informed on best practices. And if there's one regret, the presence of family. When you're in a low transmission area like ours, we never had any significant community spread. It just broke my heart not to be able to see family members get into these facilities and visit, for the obvious reasons of mental, social, physical well-being of their family member. And I would prefer a regional approach to this across Canada, where you have low community rates. You can, with due diligence, allow family members to continue to visit and support their elderly. And all of this done with appropriate PPE and best practices in place. We're doing longitudinal simulations with our medical directors. So every week we add information of starting with a COVID-19 outbreak, and then getting into an influenza outbreak, and then dealing with both outbreaks at the same time. And there's, this will be differential across the country on how people respond to this, but the The ability of a facility to cohort for COVID-19 and cohort for influenza will be different. We'll stress staff because they'll be in their PPE in those separate units. The testing is different, so you have to understand if you're going to have influenza and COVID testing capacity heading into the fall or any other pathogens. And you're going to need outbreak response for both of these. And clearly a prevention strategy with maximizing your immunization. So if we had key messages from our partnership locally, it was be proactive, use the rule of C's of communicate, collaborate, coordinate, bring in all of your partners as we try to do to support our long-term care facilities and retirement homes. That's certainly facilitated when you have a regional health authority model, but we're learning to work more cohesively in Ontario even without that model. There are best practice documents that are available to us to review and to implement for our own practices. And I'll stop there and hand it back.
So thank you very much, Dr. Moore, for your great presentation. A lot of the key messages that I took from your slide deck and your presentation were the importance of those long-standing relationships with the community, as well as acting early in the pandemic and extremely well-coordinated communication with all the players to ensure that messaging is received by everybody in a consistent manner. So thank you very much for those lessons learned, and we look forward to further discussion during the panel. But now I'd like to pass over the webinar to Ms. Teresa Miller, and she is a resident in a long-term care facility in downtown Kingston. So Teresa Miller, I will pass over to you.
Thank you. Hello.
Hello.
I'm a resident of Providence Manor, and I feel that they took excellent care of the situation. All the residents were screened for the virus very early. Our tables were arranged with, instead of having one sitting, we had two sittings, so they could arrange the tables so we'd be all 6 feet apart. Staff were all very good at wearing their masks and whatever. Very few activities, but if they did activities, they would come to our rooms individually. Perhaps it would be darts, and we'd throw a dart at a ball on the dartboard. Or maybe we would be playing ladder ball, and we'd have throw a ball with two balls with string in between, and have to throw it to hit those ladders, the rungs on the ladder, and each one be a value of different points. And then the worker would go on to another room, come back and tell you who the winner was. And we've always been fed very well at Providence Manor, I must say. I've been here 2.5 years and have had excellent care. But I volunteered here for 38 years prior to coming in here. First 12 years it was just 1 day a week. The next 24 I was in 3 times a week. So I knew the place well, and I knew it always had a very good name, and was happy to become a resident here. There was no making any choice among 3 places. I only put my name down for one place, but I really and truly feel they have done a very good job here. Also, our temperatures are still being taken every day, so I really believe that Providence Manor has done a tremendous job. Any questions you want to ask me?
I don't think there are any questions at the moment, but thank you very much for sharing your experience with us, Ms. Miller. And I'm extremely pleased to hear that some of those strategies are continuing on into the fall, like temperature checks. So that's really great to hear that you're also very well taken care of during the pandemic and into the fall now. And thank you for sharing your experience with us as a resident. Now we will actually move on to a broader discussion with multiple people from KFLA. So I will present to each panelist and then we will dive into the discussion. Taking part in our conversation today are, of course, Dr. Kieran Moore, Dr. Pierre Robichaud, Ms. Crystal Mack, and Dr. David Barber. So Crystal Mack and Dr. Barber are both from Providence Manor, and Providence Manor is part of Providence Care, an organization which has a unique place in the southeastern Ontario region, providing a range of healthcare and services at Providence Care Hospital, Providence Manor Long-Term Care Home, and community locations across southeastern Ontario. Providence Care is a Catholic health organization with a mission to instill hope and enhance quality of life of the people they serve. Fully affiliated with Queen's University and St. Lawrence College, Providence Care is a center for healthcare, education, and research. With 243 beds, Providence Manor is the largest long-term care home in Kingston, with 6 resident home areas. Most rooms are private and share a washroom with the adjoining room. Planning is underway to replace Providence Manor with a new home in 2023. So Crystal Mack is the administrator of Providence Manor, a place where she cut her teeth 40 years ago. Crystal has held a variety of roles at the Manor, from volunteer, personal support worker, private paid companion, recreational staff to staff educator, nursing supervisor, and program manager. She has also worked as director of care and assistant administrator at the municipally operated Rideau Crest Home and has been a clinical instructor in nursing at Queen's University and St. Lawrence College. Crystal has also served as program manager at Providence Care Hospital and Mental Health Services. Dr. David Barber has been assistant professor at the Department of Family Medicine at Queen's University since 2008. Prior to that, he spent 8 years working at a multi-specialty group in Indiana. Within the Department of Family Medicine, he is the lead for information technology and the care of the elderly program and is medical director at Providence Manor. His research focuses on primary care electronic medical record data and is co-chair of the Canadian Primary Care Surveillance Network, as well as the network director for the Eastern Ontario Network of CPC-SSN. He lives in Kingston with his wife and 3 children. And Dr. Pierre Robichaud is the medical director and practicing physician at the John M. Parrott Center, a 168-bed municipally owned long-term care home located in the rural town of Napanee, Ontario. Additionally, he works as an emergency physician and hospitalist at the Lennox and Addington County General Hospital, where he also serves as the acute care director and a member of the COVID-19 leadership team. He obtained his medical degree from the University of Toronto and completed his residency in family medicine at the University of Ottawa, including an enhanced skills fellowship in geriatrics, palliative care, and critical care. He completed an HBA from the Richard Ivey School of Business and enjoys thinking about health system management. Outside of work, he enjoys gardening, mountain biking, and most importantly, spending time with his family. So I think I'll pass the first question off to Crystal Mack. And so the question is, was there anything unique about your institution that helped you prepare for and respond to the pandemic? And so I'll give each panelist approximately 1 minute to respond, and then we'll move on to the next one.
Thank you. I think that the community relationships can't be overstated. I think Dr. Moore has touched on them. You've commented on them in the intros. We really benefited from being as part of the corporation of Providence Care, where there is so much expert knowledge internally, but also how we're so able to, through our community relationships, just tentacle into public health, into the Queen's medical students, to the colleges and other institutions around the city. So we've just had the privilege of working really closely to reach into the organization and then beyond, locally and regionally and nationally, even globally. We have been fed information that has been so integral to our response times, and we've had the support locally to be able to mobilize the way that Dr. Moore identified.
That's great. Dr. Barber, do you have anything to add?
Yeah, I mean, I think that certainly our relationship with the public health made a big difference. I mean, we have a really good relationship. We meet with them regularly, and so when things started off, we had somebody there that we could rely on for answers. Beyond that, I mean, we're affiliated with an academic institution as well at Queen's, and we had a good idea early on as to what was going on and what we needed to prepare for. And communications, started quite early in February. And then I have to say, as well as we have a full-time infection control person, absolutely critical. And as well as the Providence Care Institution, with other levels of knowledge, and Providence Care was sending out bulletins as early as February 5th. So we had a lot of advanced knowledge. We had great communication. The focus that KFLNA put on primary care was absolutely critical in keeping Kingston safe. I mean, that was, to me, the game changer and what makes us stand out from many other communities across Canada.
And the same question to you, Dr. Pierre Robichaud. Anything unique about your institution that helped prepare and respond for the pandemic?
Sure. So we derive a lot of benefit, I think, from being a municipally owned home, not-for-profit, and being part of a smaller community where we have a lot of links with so many community partners. I'll give you a few examples. First of all, so in response to significant PSW staffing challenges that everyone is faced with, our municipal council approved a budget to include a new position called a resident support aide, which was a great measure, a concrete, actionable measure that we could implement to help with a variety of tasks. And this role was really aimed predominantly to be there to help residents in many different ways, but also helped our nurses and PSWs with the significant challenges related to the pandemic. An additional example would be, because our management team is well connected with our community as a whole, our municipal leadership team redeployed a lot of different non-essential workers to very early on work in our homes. So that included staff from local libraries and museums that helped bring innovative ideas and different perspectives, but also just really worked hard to help with new tasks, predominantly our screening initiatives. And then finally, our management team was well connected with a lot of important health partners, and I myself had the benefit of being on the local hospital's COVID leadership team. So earlier on, when there was so much chaos and directives coming from all over the place, we had a lot of people to bounce ideas off and to collaboratively address some of the early challenges. The big two were PPE supply chain management and PPE sharing, where as a community we really felt that everyone was working together to make sure we were all safe. And the second one was timely access and turnaround times for COVID swabs. Dr. Moore mentioned a little bit about our local hospital's response, and they were really great in reaching out to all the nursing homes, retirement homes, and saying, if you need residents or staff swabbed, we will make sure it gets done. We will work together to make sure there are no barriers there. So I thought that was great thing for our community.
And Dr. Moore, anything to add to the discussion? Oh, you're on mute.
Am I okay now?
You're good now.
I very much like what all of our partners have said about collaboration and coordination, and I have to sing the praises of our primary care once again. Our first cases were actually detected in our rural environment. I actually thought we'd detect them in Kingston, and they picked up cases in Verona and Sydenham and other areas of our community, and they were individuals that were working or about to work within our most remote long-term care facilities, and we've heard very bad stories across the province of some of the rural and remote long-term care. And because our primary care partners stood up, they tested in their practices, they tested early, they put on appropriate infection prevention control, they controlled it for us. They limited the spread. We could have had very negative outcomes, but they felt confident to test and limit the spread. And without them, yet we wouldn't have succeeded in that first wave.
That's great to hear. The proactiveness of the primary care and limiting this community spread of the virus. So our second question, so I think I'll start with Dr. Barber. So what were the unintended consequences of the policies that were released? So we know that there have been many, and according to Dr. Moore's presentation, they started coming out in March. And I'm sure there were multiple ones that perhaps went against each other. So what were some of those unintended consequences that you lived or experienced?
Yeah, I can mention a couple. I think, one of the certain unintended consequences is just the isolation of our residents at Providence Manor. That's just starting to come out, the impact that's had on, mental health, mental well-being. And so, that's something that we've, tried to deal with. And it was nice to hear the patient representative, speak highly of what's being done at Providence Manor. I think one of the other unintended consequences, we were testing so much that we ended up with a false positive at one point, which was really quite scary. Although, I have to say that it really, was almost a test for us to make sure that we could manage that appropriately. So certainly unintended consequences, but it did have value.
And Dr. Hugusho, from your perspective, any unintended consequences?
Yeah, I would echo Dr. Barber's comments, particularly the biggest negative consequence was just the social, emotional, psychiatric, physical ramifications of isolating, our residents who are, inherently isolated to a certain extent to begin with. And it was a huge burden on our residents, but I think also quite emotionally taxing for the staff and families. They had a lot of challenges there as well. I can speak to some of the positives that maybe came out of that, because I'm proud of our team for really working hard to try and overcome some of these challenges. Some examples that I wanted to highlight were we were able to facilitate a couple outdoor musical events for our residents, and actually involved some family members who were musical, and that was great because it provided some engagement and stimulation for our residents, but also I thought was a great way to allow family members to contribute in a meaningful way, because as we all know, family members were just really trying to do anything to be there in any way for their loved ones. Mm-hmm. When we saw the physical and emotional kind of deterioration, we tried our best to develop physiotherapy kits that were isolation friendly and activities kits to help engage and stimulate residents. So we were kind of brainstorming there. We had handballs and door pulley exercise equipment and stuff like that, which are new things we did. We also have a breakout day where we now celebrate. Everybody comes out of that initial period of isolation as a sort of a mini socially distanced celebration. And then I thought the final thing I wanted to mention was, again, with our local collaboration, there was such a sort of pressure and focus on avoiding unnecessary transfers to emergency departments and acute care institutions. And our hospital is literally walking distance from us, and we have a great relationship, and we were able to build some internal capacity to do things like even blood transfusions in the long-term care facility. And so that was great because not only was that valuable at this time, but it's going to be a skill and a partnership that we'll be able to carry forward far beyond COVID.
Yeah, well, that's great. And Crystal, Mac, anything to add?
Yeah, well, I would like to say that, certainly some of the positive, as Dr. Robichaud suggests, is the sort of creativity that we've had to evoke around, we're fairly well prescribed about what we can and cannot do by the Long-Term Care Act. And there's been the lifting of, in some of the emergency orders, there's been some allowance for looking creatively at how we can handle situations a bit differently, and the question now, of course, is what's sustainable. So we're learning about some of our regular processes and thinking, is this something that we can actually make a recommendation that we pursue beyond the pandemic? So that's a really helpful opportunity. I think some of the unintended consequences that have had the biggest impact is resource allocation in terms of staffing, and it's been said a few times, but initially we've had the opportunity to deploy staff creatively within the home and within the corporation, and we also, as Dr. Robichaud suggested, did creative intervention with bringing in a resident support aide as well. Now that was very helpful in the initial part of the lockdown, but as we open up, what's happening is there's an exodus. So if those are students, then they're able to return to their class, to their studies, and so that pocket of people is no longer available to us. So it does create a disparity where we sit right now. So again, we have to look creatively about how to create something that will serve us now.
And Dr. Moore, from your perspective?
Well, I did hear regularly from family members in the community and brought them in to the discussions on a regular basis and tried to inform my discussions with medical directors as well as with our province who are making these decisions. I always asked for a regional approach, whether it was within the economy, our schools, or our long-term care facilities. And I hope going forward that the number I watch is around 10 per 100,000 per week. If you get above that, there is a risk of transmission into congregate settings. That was work done by our federal corrections partners where they saw infection spread into their facilities when that number was reached. So 10 per 100,000 is a number to be sensitive to, and certainly 20 per 100,000 is a number where you should potentially enhance your protocols and consider limiting visiting. That will fluctuate across the province. Those are numbers that we're watching closely, and I personally don't want to ever see a shutdown again for this vulnerable population. And I'd love us to allow families to continue to be involved. And I don't know if the patient's still on that can give us an opinion or feedback. Teresa.
Is Teresa still with you, Crystal?
Yes, she is. She's still here. She just, go ahead, just speak a little louder, Teresa.
Okay.
It was wonderful when they started allowing window visits.
Oh.
Yeah.
Downstairs, and the visitor would added the visit. I haven't had one of those yet, but I'm having one this afternoon. One of my sons from Dundas is coming. No, Dunville. He used to live in Dundas. Now he lives in Dunville. He's coming this afternoon. And my daughter from Lansdowne, he's coming on the train this time, so she's going to pick him up the train. Added the in-house. I've had 2 of those visits. My one son, Paul, has come. All taken care of here.
And prior to the window visits, were you able to do some virtual visits with family?
I don't have that. Oh, I did one.
Okay.
Activity girls came up with a cell phone one day, and I did one with my son Paul.
Okay. And how did you find that?
It worked out very well.
That's great.
I think it's wonderful how we've been taken care of in every situation.
And Crystal, have you noticed a difference in the residents now that family are allowed back in different ways?
Yeah, I'm hearing a lot from a lot of people how grateful they are, even from families who, obviously it's a reciprocal relationship, and people are really overjoyed to be able to have the people that are important to them back in closer proximity and visiting in the building for sure.
Mm-hmm. So our final question, so how are you preparing for the fall? Any lessons learned? So I'll start with you, Dr. Robichaud.
Sure. I mean, from a medical perspective, a couple important things. We're really prioritizing ongoing and comprehensive goals of care discussions as a key point to be prepared ahead of time should there be any surge. We work closely with our pharmacy on a regular basis, but in particular ensuring that our influenza vaccinations and Tamiflu orders are all optimized, and really focusing on supply of medications to make sure that antibiotics and or palliative medications are addressed. In preparation for a COVID influenza surge, I do have to say, just to echo Dr. Moore's comments, that public health locally has done a fantastic job in helping guide all of our homes and get us thinking and brainstorming about different situations and scenarios. Over the past several months, our institution, and I can only speak to our institution, I imagine others have reduced our admission frequency to build up internal capacity. So we now have several rooms that are empty in different home areas, different floors, to help absorb a potential surge in COVID or influenza cases. Certainly there's a lot of attention on staffing contingencies, and I'm happy as a medical director that it's not my primary job, because it would be it's certainly a very difficult thing to address. But I know, speaking with our excellent administration, they're looking at exploring different PSW rotations, reaching out to retired staff to see if they might consider some part-time work, and also doing a lot of work on cross-training staff to cover each other's roles. And the final point I wanted to make, just in terms of what were key learnings for us, is I think a key success factor is just a really strong communication platform. And our management team and our director of care really excelled, I thought. They expanded our newsletter platform. We now have emails for every single resident and family contact, and it's been really important to regularly communicate relevant COVID updates, but also, I think, praise the good work that's been done. So many of our staff members have sacrificed time with family and really committed themselves, and it's important to recognize their efforts, and so that's an important thing. And the interesting thing that we used that communication platform for was, just in light of family members now being able to spend time with residents, we're kind of publishing a list of COVID-friendly safe activities that our family members can do, including an interactive sort of walking map where there's scenic viewpoints and wheelchair accessible walks for family members to undertake with their loved ones. Because we're certainly always a bit cautious that as we open things up, we want to make sure that people are still making wise and safe choices when they're together outside of the home.
Great. And Dr. Barber?
Yeah, so I mean, I think continuing the communications that we've had with public health is going to be critical, and really we've had pretty much weekly meetings with the medical directors in our region, along with the public health, which is really quite extraordinary, and has been really helpful, and it's going to be even more helpful, I think, as we move into the fall season. Right now we're organizing how we're going to cohort patients, and public health is really engaged with that. The other piece is with influenza, and we've started planning for influenza back in June. We've had more than a few meetings to discuss this, and making sure that there aren't any bottlenecks, and that when the vaccine's available that same day, we can get the cart rolling around to immunize our patients. And I think even more important is our staff, and our staff has always been amazing at getting flu shots. We have an extraordinarily high rate of immunizations in our staff, and I think this year we'll even get higher based on COVID and how important it is to get that done.
That's great. And Crystal, any lessons learned or any additional preparations for the fall?
Yes, echoing again the tabletop exercises from public health. They've been very instrumental in us really starting the conversations and keeping the conversations going. And they're kind of fun, actually. It's just really fun to sort of sit as a team and, decide who's going to do what and how it's all going to look. One thing that we did very early on in the pandemic here was we created a transition unit. That's affectionately the unit where anybody that's returning to the home or coming in as a new admission spends 14 days in that space in the home. Geographically, we have the luxury of having a space that has 8 beds wherein these residents are housed. So anybody returning from hospital that meets the criteria for needing a 14-day quarantine is in that area of the home. So in some ways, aside from our false positives that Dr. Barber talked about, our drill, we learned a lot from that, but we're learning a lot about what we need to be able to use this same type of model to create the units that are going to support people with the various, COVID or influenza or the unwell unknown. So we're kind of using that as our base of knowledge for how we need to prepare other areas in the home.
And Dr. Moore, I mean, building on all the lessons learned, and there's a question in the chat box, do you foresee closures again in long-term care facilities to essential care partners and families if a second wave, well, clearly, as we move forward into the fall?
Yeah, we may have to. It will all depend, I hope. We'll be data-driven in our decision-making, and we won't make uniform, cross-province declarations of closure. I hope we'll be data-driven at a regional level to allow the participation of family members in the care of their loved ones. I think that's essential. That's a key lesson learned for us. As well, I think vigilance is really what's key. I've heard from medical directors, I've heard from nurse leads and administrators. Audits are really important. Going in and just re-emphasizing that you're putting the equipment on properly, you're taking it off properly, you're washing your hands, you're wearing your mask. All that's essential to protect our healthcare workers and also our families and patients and clients. If we can limit the spread back into this vulnerable population, it will be through good use of IPAC. And good adherence to the best practices. And all of that takes auditing, takes energy, takes vigilance, and we can't let our guard down. There's a lot of unknowns heading into the fall. The next 8 months are going to be crucial to protecting this population. And the simulations are helpful, tabletop exercises, thinking through these problems in advance of how you're going to cohort patients who may have COVID, separate from those that have influenza, separate from those that may have RSV. If those viruses do get into our facilities, and how will you staff those? How will you get enough PPE for those venues? And at that time, you may have to limit family members when you're in an outbreak mode for that defined period. But you've got to think it through in advance in this quiet time because things will accelerate into the fall. They always do, as anyone that's worked in this field knows. And also keep up the testing. Our facilities have been great. Our physicians, nurse practitioners, nurses have been great at maintaining good testing for outbreaks and or for COVID. And I'm very happy to continue to monitor that high testing rate because it's through that vigilance that we'll be able to detect the entrance potentially of the viruses, but hopefully it'll be minimized because we've been so much better at infection prevention control and adherence to best practices. But it's human nature to let your guard down over time, and we need means and methods to reinforce the best behaviors, whether you're in acute care, primary care, and or with working with the most vulnerable members of our community in long-term care and retirement homes. So stay vigilant.
So I know there's lots of questions in the chat box, but I think due to time we won't get to them all today. So we promise to connect back with all of our presenters today to make sure that we get answers to all of your questions. So I want to leave us on that note to stay vigilant, especially as cases continue to increase across the country. So thank you very much to all of our speakers today. So Ms. Miller, from sharing your experience with us. From a resident's perspective at one of the long-term care facilities in Kingston, Dr. Hobichaud, Dr. Barber, Dr. Moore, and Crystal Mack, thank you very much for sharing your experiences and thorough preparation strategies and prevention strategies in the Kingston area. So thank you very much, everybody. We appreciate you taking the time today to share your experience with us. And thank you to all those who participated on the call today for listening in on the experience of Kingston and participating in the chat. So thank you very much. And I guess now before you leave, we will just move on to the polling questions to hear from you how the webinar went today. So thank you again.
Ladies and gentlemen, this concludes today's conference call. Thank you for participating. You may now disconnect.